Greetings. Thank you for joining us today. I'll be presenting an Ebola update. And if any of you want to interact in the Twitter sphere, here is my handle, unsymbolize. First, just like to say a few words about my dear friend and mentor, Paul Farmer, who was the chair of our Department of Global Health and Social Medicine, and we lost last year. He was a well-known physician, medical anthropologist, and humanitarian, and led our efforts in the West Africa Ebola outbreak via his being chief strategist of Partners in Health, raising lots of money and setting up facilities, prioritizing treatment for people suffering from Ebola, and he is dearly missed. As far as disclosures, I have no financial relationships with commercial entities to disclose, and let's get right into it. Ebola virus, which is the genus, is in the family of filoviruses. It is an enveloped, non-segmented, negative sense, single-stranded RNA virus with 7 genes, and there are now 6 species, 4 of which cause disease in humans. Here's an electron micrograph. Pathogenesis, there's cell entry and tissue damage, gastrointestinal dysfunction, systemic inflammatory response, coagulation defects, and impairment of adaptive immunity. And as you know, the worst manifestation is hemorrhagic shock. Untreated, many of the species can have up to 70% mortality rates, but as we'll see, that's a total social construction, because with a good ICU that you may find in ICU in Europe or in the United States, in other areas, you can get the mortality rate down to as low as 5%. So I'd like to start by describing my experience in Sierra Leone, so you can see how far the science has come over the past 7 years, 8 years. We started in Sierra Leone in 2014, where I was the clinical lead for Ebola, Partners in Health's Ebola response. And containment looked like this. People would call this number 117. Information would go through these people manning the phones, and they'd send out the information to these district Ebola response centers. I was working at the DIRC in Kono district, which is pretty famous for having lots of diamond mines, lots of riches under the ground, but nothing in the way of health facilities, roads, educational infrastructure to show for it. And we'll talk about that in a bit. The case definition back then was either contact with the suspected, probable, or known case and fever, or contact and any of these 3 symptoms, or unexplained bleeding or miscarriage. So it was really difficult early on in 2014 to distinguish malaria, typhoid, or even somebody having an abortion or miscarriage from an Ebola case. And a lot of times these people were put together and sent off to isolation for testing, which could take up to 7 to 10 days to get the results back. So there was a lot of nosocomial transmission early in this outbreak. And I'll show you why that's changed over the years. So we would send out an ambulance to gather the patient and take them for testing, isolation testing and treatment, but there wasn't always treatment available. So I first started out at a Doctors Without Borders mission in Kailaun, where they weren't allowing us to put in IVs for people in shock. They thought it was too dangerous for the healthcare staff. And so, you know, that a place like that had higher mortality than places that were putting it actually, you know, giving IV treatment. I soon moved to Partners in Health, where Paul Farmer was prioritizing aggressive treatment for all patients. Safe and dignified burials are a very important part of the response, as Ebola corpses can be very contagious. This was run by the Red Cross and Red Crescent, and they did a very good job. I don't think they had any staff infections even after 7,000 plus burials. Here we are going house to house, doing community sensitization and active surveillance. We had partnered with the Sierra Leone military to do this. Here is what a large Ebola treatment unit looks like, but we started moving away from these because they took around 2 or 3 months to build. And by that time, the outbreak had moved to another district. So instead, we started this decentralized response where we were building these small 12-bed units that we could put up in about a week and train everybody in a week and get them rolling and allow people to get care closer to home and allowed a platform for community sensitization. Here's what they looked like almost complete. They were supported by UNICEF. Here you see our offices up front. This was the red zone back here. Patients would come in, a dry tent, a wet tent being for people with symptoms of diarrhea and vomiting, and then showers, latrines, and a morgue back here. Here was our case management protocol back then. So we would give vitamin K for any bleeding or hemorrhagic manifestations, empiric malaria treatment, ceftriaxone and metronidazole for there was this presumption of gut translocation causing extra sepsis. So people were treated with that, Ringer's lactate. And then when people could take orals, we had oral versions of all those medications. Now let's fast forward from the 2014, 15, 16 West Africa outbreak to 2019 in DRC. How had the science progressed? So we had a vaccine. Here I am receiving the Merck vaccine, which is a single dose for the Zaire species, very effective, over 90%, but some pretty strong side effects. I felt like I had malaria for a couple of days after that, but I also felt much safer in the red zones. Here's the construct, so the vesicular stomatitis virus. They would clip out the glycoprotein gene, transfer it to the VSV so that it would express the GP protein. And then it was a weakened version of this, I think it's a cattle virus, that was then injected into people, still making them sick. There was another construct from Janssen, a prime boost, which was derived from an adenovirus expressing a variant of the Zaire species. But then there was a second component, a filovector, which had the Zaire, Sudan, and Marburg and Tide forest nucleoprotein inserts. I guess I felt a bit optimistic that this one was out there because the new outbreak that started last year in Uganda was the Sudan species. But the problem with this virus here is that the second component gets injected 8 weeks later. And so it's not really helpful in the acute outbreak setting. So as we'll talk about, they had to come up with some new vaccines to test, which unfortunately, fortunately, I guess you could say, we didn't get to test, but the outbreak ended quickly enough so that there's no longer circulation. One big improvement in the DRC outbreak was diagnostics. So Cepheid had come up with a gene expert cartridge for Ebola, and this allowed us right at the isolation unit and treatment unit to test and get results within 2 hours, greatly diminishing the problem of nosocomial transmission that we had in that West Africa outbreak. Here we are with WHO doing a vaccination campaign, but you know, in this village of over 200 people, I think we only had 8 or 10 people vaccinated. And so although we have some great tools now, including vaccines and monoclonals, one of the problems is uptake. And a lot of people are chalking this up to misinformation and whatnot. I'll show you a quick copy of the book I wrote where I trace it back to colonial and neo-colonial legacies. Care did improve in the DRC outbreak. So here I am at Alima, where they had these Ebola cubes, which made it safer for the healthcare practitioners, but allowed us to do a lot more as far as monitoring, labs, and then admission of the monoclonal treatments. Here are the therapeutics that were available in the DRC outbreak. So we had the ZMapp and remdesivir that were there earlier, but Regeneron had come up with a cocktail, and then we had another single monoclonal antibody cocktail. And the trial for these was stopped early, showing that the cocktails, especially when given early, and that was part of the problem because people were showing up very sick, but when getting these early, also over a 90% cure rate. So we have over 90% vaccine, at least for Zaire strain, and over 90% monoclonal. So that science part has been solved, but getting these products into people's bodies is another story. Here we go, and fast forward again to the Uganda outbreak, which started last year in September. And the difference here was that it was the Sudan species. There were 142 confirmed cases, and at least reported, and 87 recovered. So that was a case fatality rate of 39%. But there were also 22 deaths among probable cases, raising this overall CFR to 47%. And this is most certainly an undercount, as my group has published, at least from the West Africa outbreak, when we did serosurveys afterwards. There's a fair amount of up to 20 to 25% asymptomatic Ebola infection, and then a lot of missed cases as well. So these are certainly under reports, which after post serosurveys will show. This is what was reported. Teams did a great job of following 4,000 contacts for the incubation period of 21 days, and then after 2 incubation periods of 42 days. This outbreak was declared ended on January 11th. Here's what the case counts look like, at least reported cases. This is a week in the year, all the way towards the end of the year. And then we have the 42-day period with no cases, and it was declared ended. Here's a geographical distribution. So here's one of the things with Ebola that also makes it difficult to contain, that with a average of 6 to 10 day incubation period, it gives people time to travel once they're exposed. So we actually had cases in districts that weren't next to each other, but Ugandan ministry along with NGOs and WHO did a great job of containing it in a 3-month period. There were 3 vaccines that were approved by the Ugandan government for field testing. 2 of them had an adenovirus construct, and then another one was based on that Merck vesicular stomatitis virus, which we had discussed earlier, which had then been licensed over to the International AIDS Vaccine Institute. All of them were single doses, making them appropriate for an acute outbreak. Some were already available. They realized a month late that they had about 100,000 in the freezers. The problem with those is that frozen bulk vaccine can take 60 to 90 days to get out into vials. So it's also not quite ideal to be stored in that fashion for future outbreaks. So it raises the issue, and this is the big scientific and containment issue for future outbreaks. How do we get shots ready for vaccines that aren't approved for future outbreaks, whether it's a Sudan species or other species of Ebola? And we have Mike Ryan here in an interview with Stat saying, if we want to be truly strategic, what we should be doing is having ready to go trial platforms in a set of countries with products ready to go. That requires a huge effort on everyone's part, and an effort that doesn't result in immediate results. It actually costs a lot of money too, because you could have these vaccines waiting for outbreaks that never happen, and when they expire, they have to renew. So he continues, you could develop these products, have them in clinical lots, and you could develop the trials platforms, but never use them. But other than going in and vaccinating large populations now with vaccines that we already have approved, say for in areas where Zaire circulates, in order to get this testing done, since we're getting better at containment, we're going to need stocks, and stocks that aren't just frozen and in bulk, ready to go to run these trials. So that's the big issue, virologically speaking, going and anticipating future outbreaks. And I said I'd mention earlier that, to me, one of the big issues is not just having these tools ready, not having the lab work and the science done in anticipation of outbreaks, but it's actually acceptance of on the ground of these products whether they be monoclonals for treatment or vaccines for pre-exposure. And so I wrote a book based on my experience in the West Africa Ebola outbreak, talking about the colonial and neo-colonial determinants that we really need to focus on so that this trust of foreign groups coming in is built. And so any of you that are interested in that side of things, I recommend my book, with the foreword by our friend Paul Farmer. And with that, I'll say thank you for listening to this Ebola update. Here's my email and if there are any further discussion. But again, I thank you for your attention and Godspeed.